What we're going to talk about now is almost the opposite of what we just talked about in my career, which has been a long time. Started doing this back in 75, 74. Maybe I've picked up one Boerhaave syndrome. Now, I want to give you some idea of somebody who's seen 160,000 patients, how often some of this happens. Not very. But now we're going to talk about dizzy. Now, I know what you're thinking. I know what you're thinking when you look at the rack, and the charts are sitting there, right? One chart. And then it says, allergic to everything known to man, all right, and has been itching for 28 years. Terrific. That's sitting there. And the next one says dizzy. Is there anything worse? Yes, weak and dizzy. Is there something worse than that? Yes, weak and dizzy, and a history of fibromyalgia, since age 2. Now you should take me and shoot me, okay? Because we got to know who's going to pull that chart off the rack. I'm going to talk earlier about examination, but examination is absolutely essential in the dizzy patient. Because there is no such thing as just dizzy. Get that into your head right away. Terminology, dizzy. What does it mean? Anything you want it to mean. What's the matter, sir? I'm dizzy. Now, can you give me a few more hints? Take me somewhere. Give me something. But I want you to be able to divide these patients into 4 groups. Because 3 of them, you're going to do almost nothing with. One of them, this may be serious, so think about it a little bit. 3%, 3 to 4%, depending on whose study you look at, of the people who come to ED say they're dizzy. That means if you're seeing 25 patients today, your odds are you've got a dizzy patient, right? Are you going to have a headache patient? Yes or no? Yes. Okay, this is what we do for a living, so you ought to be good at it. There's a lot of it around. What is disequilibrium? That's a feeling that the world just isn't right. And this disequilibrium syndrome is very tough to know exactly what it is, but you have to use a series and logical questions to put it in the order that you want. Pre-Syncopy, what's that? Well, that feels like I'm going to pass out. Now, the causes of syncope are exactly the same as the causes of pre-syncope, only you didn't pass all the way out. But syncope, pre-syncope, it's a feeling that they're blacking or graying out. It's not dizzy where they say they're spinning. Those are quite different. Pre-syncope and syncope are almost always in some way related to blood flow to the brain at that moment in time. Did they just have their medications changed? Look at the number of people who come in. Don't you always love it when they say, you say, well, where are their medication jars? And they say, well, we're getting the lift truck to bring in the bag. And then you sit down with the family and you start going through it. Does anybody actually know what they're actually taking each day? No. Half the people aren't even sure what they've got. But when anyone has had a change of medications or they've added something like that, God, take a look at it in the quote-unquote dizzy patient. Because that may not be what it is at all. But they could have increased this, they could have decreased that, and it's not right. It's not good. Now what we're going to talk about, and most of this talk will be spent on vertigo. That's a sense of spinning, but it is not blacking out. The vertiginous patient is not the one who blacked out. or stood up and went down suddenly. It's a sense of movement. Now, when I was young in this business, that was a long time ago, I took care of Lincoln. It didn't go well, all right? The bottom line is when you have a vertiginous patient, they actually have that sense of movement. Now, we used to go through a whole series of questions to decide whether it was objective or subjective vertigo, all these sorts of things. That's all gone now. People found out it didn't make any difference whether the room was moving or they were moving. None of that makes any difference. It's all the same disease process. But it's a perception that the environment is moving. Vertigo is only told by the history. I'm going to give you a suggestion right now. Whenever they say, I'm dizzy, shut up for a minute and ask them, what do you mean by dizzy? What does it mean? Let them talk for at least 10 seconds. I know how hard that is for you to do that. There's a very good study that shows that emergency people interrupt the patient about every 8 seconds. If you think that's an overstatement, just watch and see what happens in your own department. But they will give you the diagnosis. They will come down to what's important for them at a certain point in time. Ask what else is going on and look at the patient. We're going to talk later about neurological examination. But that is the number one exam you have to be good at in an emergency department. A lot of you pull out the stethoscope and put it on the chest. What does that actually tell you in most cases? Nothing. It tells you that they've got air moving in and out, and they've got a heartbeat, lom-dom. But when you actually do neuro exams, you actually get to see the brain function. It's very useful. Very useful thing to do. By the way, we have peripheral vertigo and central vertigo. All peripheral vertigo is related some way to your semicircular canals and the nerves coming out of those into the brain. Central vertigo is in the brainstem and the posterior fossa itself. They're quite different. And we're going to see lots of people with peripheral vertigo, and we're going to see a much smaller group of people who have central vertigo secondary to blood flow to the brain and the posterior fossa. That list, which is in your book, is worthwhile looking at. It does help to orient you. And I'll just tell you right now, the usual healthy 19-year-old who comes in and has got whirling vertigo, when he gets out of bed, first question is, what did you have to drink last night? We've seen lots of people with the whirlies. Anybody here ever had the whirlies? Yeah, you have. Okay, don't you lie to me, okay? You decided to take a course in Vegas. Some of you are going to have the whirlies while you're here. But the point is, it can be very intense, very sudden. They feel like they're going to die, but they're not. This is not the bad kind of vertigo problem. This is the better kind. So you ought to know what to look for, and we've got a list. We've got a list here, or we've got the diagram in the book, which is really very useful. Because it takes that patient who says, I'm dizzy, and puts him into one of 4 groups. You need to do that to proceed ahead. Because not everybody who comes in with vertigo needs to have a diagnostic study. And I'll just tell you, I'm an anti-test doctor. The vast majority of people I see do not get tests, or they get very few tests. But the way you do that is with history. So what are the causes of peripheral vertigo? Just think about it. Semicircular canals, what's going on? Can they get it from a viral infection? Sure. Very few people with a bacterial infection actually present with a vertigo. It's an unusual sort of case. What about people who have Meniere's disease? They'll tell you a specific story. They're older. 25-year-olds don't have Meniere's in general. These are older people. They hear a roaring. They have a sound associated with the dizziness in virtually 100% of cases. Are they sick? They feel like they're going to die. They've got this roaring in their head, and then it collapses. It falls. They're going to need testing, which you can't do in the emergency department, to get the exact diagnosis, and that's okay. Most of these people are safe to let go. Medication-induced dizziness, I'm not going to spend a lot of time, but someone did a study and looked through all the cardiac medications and to see how many of them had the term dizzy or vertigo associated with them in the warning labels. Any guesses? 80%. 80%. So without knowing what they're on and whether that's been shifted, you don't know for sure. So what are we going to do to assess not the pre-syncopal patient, not one who's got the general, I don't know where I am sensation. And by the way, diabetics with significant peripheral neuropathy will tell you, I feel dizzy, and what they're actually having is with their peripheral neuropathy, they don't know where they are in the world. You have systems that tell you, orient you. You have your semicircular canals, you have your vision, and you have your peripheral sensation. Any one of those can give you a sensation of quote-unquote dizzy until we ask the right questions. I want to talk to you a minute about the HINTS exam. HINTS, if done well, and you can all go home, go up to that computer that sits on everybody's desk, and put in the HINTS exam. The last time I did it, there are 60 videos of the HINTS. Nobody should come in without the chief complaint of dizziness who you haven't done a HINTS exam on. It's almost painless. It is painless, and it's rapid. HINTS is an abbreviation for the head impulse, Nystagmus, and test of Skew. There's 3 parts of this test. And when you think about it, you sit them down. You have them looking right at your nose. Observe the eyes in the static position. For those people who've got nystagmus, little bits of nystagmus, why? They may have some irritation, something in the semicircular canals, but I want you to observe the nystagmus, because here's the rule. Benign types of nystagmus universally go in one direction. They are almost always horizontal. Anything that goes like this, that's bad. Do that again. This, that's good. Benign in most cases. Anything which shows rotational movement, bouncing up and down, side to side, up and down sorts of things, is abnormal. Most benign vertigo that we see in the department is lateral, short-term, and it fatigues. It stops doing those strange motions. They go away. It's a good thing. Now, when you're doing this, the second part of the test, you're going to have the patient looking at you, and you're doing alternate cover. What should happen when you've covered an eye? Will it drift slightly? Yes. One eye covered, you're looking with the other eye. Pull your hand away, and it will make a slight movement to align the eyes. Your eyes do whatever they can to stay with each other, to close that angle so they're focusing on one point. Eyes do that. This is a long biologic process over a billion years with animals, but it works. If you're testing it, if somebody brought in their alligator because they say my alligator's dizzy, and you're doing a Skew test on the alligator, he's not going to pass. Why? Because their eyes work independently of each other. They don't focus. Well, did you ever see an alligator's head? How would they look at one point? They can't. They move all the time. So you're looking, when you do the Skew testing, to see if there's a drift, and then when you take your hand away, if it doesn't immediately correct online, that's abnormal. For some reason, the centers, there's a area in the midbrain, the median longitudinal fasciculus, which looks at all of these things and connects 3, 4, and 6 to keep them looking in the same direction. That's what you're looking to see. Has something interfered, and in most cases it would be some sort of stroke, some sort of vascular problem that has interfered with those mechanisms. There's some pictures in there which you can look at, but when that eye is looking away, when you pull away with alternate cover, they should immediately come back together. If they do not, that's the patient you've got to worry about. Let me just do this for a second. Test of Skew, again, moving the eyes, covering the eyes, alternate cover testing. So what you're looking at is the actions of 3, 4, and 6 and their interconnections, which should be forcing those eyes to always look in the same direction. Let's talk about nystagmus for a second. Nystagmus, again, the eyes move, controlled by 3, 4, and 6. They move together. So if you've got something in the semicircular canals that are putting in information, they bring your eyes over to check a threat. They realign the eyes. That's normal nystagmus. Little bits of that are perfectly fine and perfectly normal and are not a problem. It's when they don't move together that you have some sort of underlying vascular disease. So let's put some conclusions in here. The patient who comes in with a sense of vertigo, and it could be sudden in onset, it could be slow in onset. In general, the worst feeling vertigos are peripheral and are most benign. It's that strange, funny sensation that grandma comes in with, that things aren't aligning just right. Beware, those are a problem. If you're going to get the 3rd, 4th, and 6th cranial nerves, you're going to almost always have some other problem. You need to do a decent, and again, posterior fossa. Think of where the blood supply comes off there, where the other cranial nerves are. This is an absolute. Patients with quote-unquote dizziness, nystagmus problems, need to have the cranial nerves properly examined. Again, I'm an examination guy. You're not going to find just 2 or 3 nerves. If 3 of the nerves are involved, there's going to be another nerve involved. This lets you know what part of that posterior circulation, what off the basilar artery is involved. Here are the take-home points. Vertigo is a sensation. It's a sensation, it is not a diagnosis. There's central vertigo, Think about the artery that supplies it, and peripheral vertigo, that comes off your semicircular canals. Whenever you use the term dizziness, I don't mind if you use it as a symptom. It is not a diagnosis. You don't diagnose somebody who has to have dizziness. You might say unexplained dizziness, but no specific disease entity noted. The onset of vertigo may come on slowly, particularly in viral kind of conditions. It may have come on and go away, back and forth. Why? Because the blood supply is variable back there. They may have had it, now it's bad, now it's gone away, now you're into the ER, and you may not see anything. You don't have a specific diagnosis at that moment, but you have some idea of where it may be. Sudden onset of central vertigo can happen again. The older the patient, the more likely it's a vascular problem. 25-year-olds do not, in general, and I'm trying to think in my entire career if I've ever seen a 25-year-old with an infarct there causing this. No, I haven't. Posterior fossa disease is a disease of the elderly in most cases. A CT is not really the instrument of choice. If you think they have a vascular problem, if they have a positive Hintz exam, they have a divergent gaze, what they need is an MRI, not just a CT. You want a decent look at the arterial system in the brain itself. And never let a negative CT scan or MRI overrule your neurologic examination. Don't think that that's the way to go. Exam plus the test. Because you may be catching them in between spells, in between flow periods of those vessels. So there are lots of good ways to rule this stuff in and out, but it's both physical and an X-ray study. Any other form of nystagmus, say this again for the last time, any other form of nystagmus other than horizontal nystagmus, minimal, is not right. Whenever you see eyes separate, whenever you see an alternate cover, a maintenance of skew deviation, where the eyes aren't looking at the same point, that is always abnormal, almost always vascular, or you could be related to a tumor which is interfering with vascular flow, that sort of thing. But that needs aggressive workup. That always needs aggressive workup. And any form of skew deviation, any of it, if it lasts for more than a second, consultation with neurology would be a very good thing at that moment in time. So let's think about it again. 3% of the people who come in to see you, 3 or 4, depending on whose study you look at, is going to complain of dizziness. Almost none of them have something terrible, but it's either related to the flow of blood to the brain. We stand them up, blood pressure falls, that can be a cause. We can have a blockage of a vessel. We can have medication itself, which has affected other things. But in most cases in the emergency department, what you're looking for is this: new onset of perverse nystagmus, skew deviation, or any other cranial nerve involved is considered to be a central form of nystagmus, a central form of vertigo, and is very likely the problem of blood flow going into the posterior fossa of the brain. Ladies and gentlemen, remember, you're going to see these people every day. Get it right. Do the exam correctly. And if you do, you're essentially going to miss nobody with a bad disease. Thank you very much.